Welcome to the webinar, Diagnosis and Classification of Periodontal Diseases. It's not about the millimeters anymore. I'm Joana Cunha Cruz, a dentist, researcher, and professor at the University of Alabama at Birmingham. I'm also the National Director of Communication and Dissemination at the National Dental Practice-Based Research Network. I'm interested in doing research in oral health, clinical, behavioral, and implementation science, as well as practice-based research and health equity. I'm the principal investigator for the Bridges program, which you will be hearing about it after the presentation from Dr. Gers. So now I would like to introduce you to Dr. Nicholas Gers, our presenter for the CE course. Dr. Gers is a periodontist, clinical researcher, and professor at UAB. He is also our current dean. He is interested in doing research in periodontal health, dental implantology, periodontitis, bone crafting, regeneration, and systemic health. This is a CE course provided by us to search as part of the Bridges program. But let's get started and learn why it's not about the millimeters anymore. Dr. Gers, it's with you now.
Well, thank you, Joanna, and thank you, CARE team in Alaska. I'm very excited about speaking to you and leading this discussion. Really, I want to make this a discussion about the diagnosis of periodontitis and other periodontal diseases as well. To me, it's very exciting to be part of this project. Joanna has done a fantastic job at creating a care model research and care evaluation that I think is quite unique. So we're very excited about being part of this study. So what I want to talk about is simply this. About half of our adult population in the U.S. is projected to have periodontitis. And what I'm trying to talk about is how do we get to a systematic approach that gets us to identify the people that have periodontitis and that have a susceptibility to this disease. So to do so, I first want to outline a little bit about what periodontitis is. And you may think, well, hold on, I know this. I just want to put it in a context that helps explain how we came up with this classification. By the way, if you look at this diagram here of the United States, they, of course, completely left off Alaska. They left off Hawaii and I guess Puerto Rico. And it makes it look like all periodontitis happens right here in the South, and that's not true either. Oral cavity is quite a unique environment. It is a perfect incubator for bacteria, and it is so because of the high humidity, the temperature, the pH, the carbon dioxide tension, and an abundance of nutrients, and they're all optimal for growth. Now, where does this growth happen most easily? It happens on a surface to which bacteria can attach, and that attachment is easiest to hard surfaces. Yes, bacteria can stick to your soft tissues, but they get shedded off and they don't have an opportunity to organize themselves or to multiply nearly as well as if they were to be able to settle down on the tooth surface. And that organization now allows for not just the bacteria to multiply, but to attract other bacteria into that biofilm that may not have the capability of attaching to a tooth surface, but can join a biofilm. So what now happens is that these biofilms organize themselves on the tooth surface, and on the tooth surfaces, the best place to organize themselves is right next to the gingiva. Now, the gingiva in itself is a very unique tissue. It's part of this tooth soft tissue complex that really is an anatomical situation that we do not have anywhere else in the body. There's nowhere else in the body where you have hard tissue sticking through soft tissue. And that now kind of creates the weakest link on the outside of the body. Therefore, if you also take in consideration that there's a great challenge, that microbial challenge or that challenge from that biofilm that accumulates right next to it, the body really needs to create tissue that surrounds that is able to respond to any challenges. And that response tends to be inflammation. So if you look at these two slides, this is a slide of health, and then next to it is a slide of disease. And what you see here is inflammation, likely bleeding. I'm probing if we were to touch these tissues that indicate that these tissues are actively responding to the plaque. If I look at this slide, I am also very happy that this patient has inflammation. We don't often think about it like that, but inflammation is a must-have defense to biofilm. So in a patient like this, we're mostly concerned about the biofilm, but if you have biofilm, you must have this inflammatory response because the bacteria that are right here in this plaque, they're likely in this plaque, are ones that can cause harm, potentially even serious harm to the patient and potentially even death. So these bacteria have to be held in check, and they are held in check by the inflammation that's present. I'll talk just a little bit about the pathogenesis of periodontitis, and I'll start where we left off on the other slide. So the microbial challenge is where everything starts. That is the plaque on the teeth, and I told you that must respond in a host response. And that host response initially is very nonspecific. It is polymorphonuclear leukocytes or white blood cells that come to the area, and they simply ingest bacteria and neutralize them. In the process, they signal back to the body about the level of the attack or the level of the challenge and respond appropriately. And that is kind of the acute response that inflammation starts with. But over time, that response becomes more chronic and more specific with the potential to create changes the environment. So if we get a deeper pocket, the area for the microbial challenge changes because it now selects out more anaerobic gram-negative bacteria that are worse from a challenge perspective and elicit a different immune response. So this now creates a different immune response that happens to be more rapid. So the initiation of disease from no pocket depth to a 4 millimeter pocket may take a long time, but a 4 to a 5 doesn't take as long, and a 5 to a 6 tends to be quite unpredictable, but tends to have the possibility to progress rapidly. So in this, the complexity of the disease, the depth of the pocket becomes a risk factor for future disease. Now, this host response here in this slide is really what causes the destruction. And that host response varies per patient. We have many patients that do not have bone loss occurring when they have a microbial challenge and an immune response. And in those, most of the host response is protective. So those are the people that don't have periodontitis, and the 50% that do will have that. Now, if we listen to this story, periodontitis really is an inflammatory disease. It's an inflammatory disease. It's the host response that determines whether or not you have bone loss. Yes, it is in response to that bacterial challenge, but the destruction is an inflammatory disease. And what I'm going to try to get across today is that the inflammatory disease is with the patient. We're diagnosing an inflammatory disease that the patient has, and that inflammatory disease in current day knowledge is never really taken away. So what we do in therapy is not so much about inflammation, and I hope my slides are a little bit better, although the gist of this slide should be easy to follow. So in our biofilm formation, from a periodontal perspective, everything starts with those bacteria that can easily stick to a tooth surface. They are the orange or the yellow, green, blue, and purple complexes of mostly gram-positive bacteria that are able to attach to the tooth surface. The bacteria that are more implicated in the pathogenesis of periodontitis are the orange and red complex bacteria, but they have a hard time sticking to a tooth surface. So they don't really attach unless there's a substrate provided by these early colonizers. And in therapy, we use this all the time. we basically use this cascade of events that kind of mimics the formation of a pyramid, and that you need that base first, then you need the middle, and then finally you can get the tip. We use that in therapy all the time because we tell our patients to knock down the pyramid every day, basically at the level where the base is formed, and from that we now prevent a pathogenic flora to form. So this to me is very important to understand. In addition to the structure in how biofilm is laid down, once an established biofilm exists, it's not a homogeneous blob of a whole bunch of bacteria. No, there's a dramatic structure to that. That structure includes water channels, energy sharing, nutrient sharing. So that almost mimics how we build our cities. So these city structures or these biofilm structures make that a more complex environment to deal with. And if we look at how biofilms form within a pocket, it tends to be organized in such a way that the early colonizers, the gram-positive bacteria, are closer approximated to the root surface versus the pathogens, the periodontal pathogens, are closely associated with the epithelial surface, now eliciting that immune response and having the potential to challenge that epithelial surface. Technically, all of these bacteria are outside the body. They're just sitting in that crevice or the pocket that wraps around the tooth. And those red complex bacteria do possess virulence factors to be able to breach that epithelial barrier. They have enzymes that can cleave the attachments, allowing the bacteria to enter into the tissue. Then they have fimbriae, or little arms on the surface of the bacteria that allows them to enter into the tissues. Another level of how the immune response could be agitated. So biofilm is very important to understand. I'm going to play a little video clip, and I hope that this comes across really nice and crisp, because this little video clip takes us from a clean surface to what a biofilm looks like once it's established. And in that, here we're kind of looking into that sulcus area between the tooth surface and the epithelial surface. What you see here is the tooth surface with proteins from the saliva proteoglycans precipitating to that tooth surface, forming the acquired pellicle, and that now becomes a substrate for those early colonizers to attach to. They settle down, get comfortable, multiply, and provide the substrate for other bacteria to join in that now are going to form these biofilm structures that include water channels, a matrix that wraps around those bacteria. And what you see here is an established biofilm. Established biofilms are hard to reach. If this biofilm is not mechanically disrupted, for instance, rinsing with an antimicrobial mouth rinse will have no effect on anything with the disease. So this is the slide that tells you that rinsing with an antimicrobial mouth rinse does not affect an established biofilm. Now, biofilms form with that pyramid, the early colonizers, etc. But if you get calculus, like you see here at the base of these columns, you get calculus by having bacteria die, absorbing calcium salts, etc. Now the equation changes, because that calculus in itself is a substrate that allows for the periodontal pathogens to be harbored within. And now you can't get rid of a biofilm by just removing the bacteria, because you can never fully remove the pathogens from that calculus, and they no longer need a facilitating group or that base layer of bacteria that can attach to a tooth surface to form a biofilm. So that was my little preamble of what periodontitis is. And now I'm going to talk a little bit about the disease classification, and I'll put it in the context of what I just talked about. So that classification was developed by a group of experts from around the world. And what was unique about the classification is that it's the first time we globally agree on what we call periodontitis and how we then further define the various stages of periodontitis. That discussion was a discussion at which we got to consensus, and I was there. You may not recognize me, but under this arrow, I was there. So I was part of the discussions that led to this classification. In the new classification, we're not changing the information that we gather. And it's very important to understand that this classification is built on very accurate measurements of the disease and the disease progression. And that starts with our clinical measurements. So, in clinical measurements, we can look at different things we measure. One of them is probing depths. Probing depths are essential to understanding whether or not we may have had destruction. And actually, a cleaner way to do that would be clinical attachment level measurements. That is, however, a very tricky thing to do because it requires an accurate location of the cemento enamel junction. Very easy to do in a patient that has recession, but very challenging to do in a patient like this. Because if you look, for instance, at this molar here, where's the CEJ? Well, it's slightly subgingival. It is slightly subgingival on the molar, and it's even more subgingival on this premolar. On this premolar here, for instance, we could very well measure a 4 or 5 millimeter pocket, but if we accurately locate the CEJ in relation to that gingival margin, we may find that that CEJ may be 2 to 3 millimeters subgingival. So in this case, if we were to chart pockets of 5 millimeters and a gingival margin of 0, we now say that this patient has 5 millimeters of attachment loss, and that actually is not true. If we subtract the 3 millimeters that the gingival margin is coronal to the CEJ, we now only have a 2 millimeter pocket. So for me, accurate clinical attachment level measurements are the gold standard, but very challenging to capture. If I do an accurate chart of clinical attachment level measurements, which we do in research protocols, a periodontal exam takes me about an hour to do, a complete perio chartings. So in most clinical practices, the attachment level measurements are not accurately recorded because we often call gingival margin 0 if we don't see recession. So in those cases, we shouldn't rely on those clinical attachment level measurements. In probing, it's also important to probe the right position on the tooth surface. So if you probe for instance, a surface like this is really probing the buccal surface. You get a shallow pocket, and that's okay. But most incipient disease sits right underneath the contact. So we need to make sure we find that by probing as parallel as possible underneath the contact of the tooth surface, and also preventing from over-angling this. So in this case, incipient disease would have been missed if we would have gone with just the first measurement, and we would have overestimated disease if we over-angulated. So in your clinics, you use the PSR probe, and that really has markings on it that allow you to record these probing depths accurately. If you do a PSR measurement, you're basically trying to screen for a patient that may have disease or may have no disease. What you can't do off of a PSR is extrapolate out the grading and staging. What you can do is diagnose periodontitis with it, but you can't further look at extrapolating out the exact grade, stage and grade that the patient may have. The grading may be possible because you can use other measurements. So in addition to our probing measurements, we need to find out how complex the disease is. And so we gather complexity by recording probing depths, but we also gather complexity by looking at the furcation invasion. And we do that horizontally with a regular probe. We can do that with a furcation probe as well. So a neighbor's probe would be helpful to be able to find these furcations, and they're important to find because a tooth with a furcation invasion like this becomes far more complex to manage. So that's why we need to know that. In addition to our probing, we take radiographic surveys. And I want to talk a little bit about the surveys that best capture that. If we take a bite wing radiograph, we have the best opportunity to capture the crest of the bone in the appropriate relationship with that tooth, because the bite wing radiograph is easy to position parallel to the long axis of the tooth with the x-ray beam coming in perpendicular. Now that's an accurate depiction of the bone levels. However, if we take horizontal bite wings like this, we're going to miss the bone on many of our patients that have periodontitis. So accurately finding that crest of the bone is easier if we take vertical bite wing radiographs. This is not a great example, but I found this one in one of my patients in which we capture bone levels in the mandible, but not so much in the maxilla. And it's mostly because the X-ray is not well positioned. But a vertical bite wing gives you that opportunity to capture that. For the diagnosis of periodontitis, particularly for the assessment of the bone levels, a vertical bite wing captures more information. And you can kind of see that in this example. This is a very old slide. It's even fuzzy on my camera, but I like the way that it has the same view for both a vertical and a horizontal bite wing, and how you can see that the vertical bite wing allows us to capture the bone levels and patterns both in the maxilla and the mandible with one radiograph. And to be honest with you, if you take vertical bite wings, you see a series here at the bottom in which we not only capture the crestal bone of all the posterior teeth, but we also have all the interproximals captured really well. This captures a lot of information about bone levels, as well as the opportunity to judge caries interproximally, if that's what you're using for your interproximal caries diagnostics. So if we now go back to the classification, this classification has in many ways simplified things a little bit, in that we are no longer distinguishing between chronic and aggressive periodontitis. That decision was made because the actual process of leading to bone destruction, the biologics behind that is very similar. What it also includes is a diagnosis of periodontal health, and that to me is most interesting, not in pristine health where the patient has never had disease, but once they have had therapy, are they now in a state of health again? So our diagnosis always starts with looking at the gingival diseases first. Gingivitis is a very straightforward disease that represents inflammation that is contained within the gingiva and has not affected bone levels. What is very important to understand is that a diagnosis of gingivitis also comes with an assessment that no bone loss has occurred. So if bone loss has occurred and you have gingival inflammation, you can't use the diagnosis of gingivitis to describe that inflammation. You have to really stick with the term gingival inflammation. So if you tell me a patient has gingivitis, I know a couple of things. I know this patient has gingival inflammation and has no bone loss. And that's important to know, because if a patient has had bone loss, gingival inflammation becomes a very strong indicator or risk factor for future bone loss. Whereas if they've never had bone loss before, just gingival inflammation isn't associated with a great risk for bone loss. I will also know that if I see this patient, that there are a couple of risk factors that likely played a role. Biofilm and a dry mouth are the local factors, but there are a couple of systemic factors as well that can play a role in that pattern of inflammation. Now, if we move on to disease progression, actually, gingivitis is a curable disease. It's the only curable periodontal disease. If gingivitis is left alone, it can progress to a disease that has permanent destruction associated with it, and that's periodontitis. That periodontitis now is characterized by bone loss, pocket formation, etc. Again, something that is not new to you, but if we define periodontitis, this is a inflammatory disease that has created signs and symptoms that include pocketing and bone loss. What we're really diagnosing, though, is the inflammatory disease. And unfortunately, we can only diagnose that inflammatory disease when we have had a history of disease or where we have signs and symptoms. So the diagnosis of periodontitis really is on the patient demonstrating to us that they've lost attachment. In a case definition of what periodontitis represents in the new classification, it includes you must have two non-adjacent teeth with clinical attachment loss interproximally, or you can have it on the buccal aspect, but that buccal attachment loss also has to be associated with pocket depth. It can't just be a site with gingival recession. And since we're trying to diagnose a patient with an inflammatory disease that leads to bone loss, we need to exclude bone loss that has occurred for other reasons. And this to me is very important. So if we have a patient that underwent orthodontic treatment, we move the tooth very much outside of the arch, we potentially get very thin tissue to overlie that root surface with the potential of having recession. That recession is not periodontitis. That is an anatomical feature, potentially iagenically introduced. So that's not the bone loss we're looking for here. If I have a third molar that sits behind the second molar and during the removal, we have no bone left on the back side of that molar, we may very well have a pocket. We may very well have bone loss, but that's not periodontitis. We do not include those findings in our diagnosis. And the simple reason for that is that this event here to the distal of that molar doesn't tell me anything about the risk for bone loss of the other teeth in the mouth. Now, it does present a complexity for that tooth in itself that has to be resolved, but it's a very local complexity, and it was part of either the anatomy, the tooth was closely approximated to the tooth surface, or the actual extraction that led to trauma. So in our assessment of periodontitis, it has to be attachment loss or bone loss associated with inflammation. What we now do is once we've established a patient has that, we're going to take that periodontitis diagnosis and we're going to further look at how complex that disease is and how the severity of the disease is at presentation to further stage the disease. And
Nico,
yes.
Nico, let's get a stop here before you move into staging, because we have a question about um, the definition of periodontitis before staging and grading. So, Dr. Gers, what about the situation where there is a clinical bone loss from crowding or toothbrushing abrasion in the presence of gingival inflammation without pocketing? Would this be characterized as periodontal disease, or what would you record if not?
So if this patient, and I hope I understand the scenario correctly, but if this patient has gingival recession that is associated with trauma, and that trauma could come from brushing your teeth, then that does not constitute periodontitis. It gets a little complex because most times when patients have recession, the recession is multifactorial. If you had a patient that had inflammation, had bone loss, and in the process had treatment, you will have recession. And that treatment could come from the patient itself. It could start, the patient could perform oral hygiene differently and potentially lead to resolution of that pocket depth that results in recession, but that we do not call periodontitis. No, that one we do, but if the recession is just caused by trauma, it is not periodontitis. Crowding in itself predisposes you to have worse oral hygiene, but is not one that leads to periodontitis. Crowding may complicate oral hygiene, and crowding may also create an opportunity where there is a thinner phenotype on the buccal aspect of the tooth that makes it more prone to recession. Does that make sense?
Thank you. Yes.
And I like
Thank
the
you.
fact that I get interrupted for questions, so don't hesitate to do that again.
Yes,
So
please add your questions to the meeting chat. It's very appreciated.
and Joanna, just interrupt me when one comes in because I'm not looking at the chat box directly.
Good.
So this slide may very well be fuzzy for you, but that may actually be a good thing. So from a staging and grading perspective, there are lots of parameters listed in each stage that a patient has to fit into to be able to stage the patient. But what I first want to explain is the gist of what these stages represent, because this is what we discussed when we talked about our disease classification. The numbers are somewhat arbitrarily put in there to match the scenarios of these different stages. So for me, stage one represents the very incipient disease. This is the first time the patient demonstrates to us that they have an inflammatory disease that can lead to bone loss, or that they actually have lost attachment and bone around their teeth. So prior to this, we may have diagnosed this patient with gingivitis, but now we know the true nature of that patient, and the inflammation now what we now know about that patient is that their inflammation can lead to bone loss. And clinically, we characterize that as a patient that has about 1 to 2 millimeters of attachment loss or radiographic bone loss, RBL, that is less than 15% of the coronal third. And we don't see tooth loss in this. From a complexity perspective, we see probing depths that are equal or less than 4 millimeters, and the pattern of bone loss is horizontal. So, very incipient disease that also has complexities that are somewhat easy to manage. So in this patient, we would have to manage the 4 millimeter pockets, and we often can do this non-surgically. Stage two represents the progression from this stage into a more complex disease that is characterized by more attachment loss, about 3 to 4 millimeters, bone loss that's still within the coronal third, somewhere between 15 and 33%. And again, these numbers are somewhat arbitrarily picked, although based on clinical experiences, this is how we describe that progression of disease beyond just incipient disease. The complexities now are still horizontal bone loss. Our probing depths are a little bit deeper, approximately 5 or less. And again, if treated with non-surgical therapy, with definitive non-surgical therapy, these complexities can be managed like this. Stage three is the stage of disease in which the complexities become very challenging to manage, and so challenging that now tooth loss is in play. So, what are those complexities? Well, it's deeper probing depths, 6 or greater, vertical bone loss, furcation involvement, and if a tooth is lost, often the patient's left with a ridge deformity. So, this stage also already includes teeth that have been lost or are about to be lost. So that complexity now becomes difficult to manage, and quite often do you need surgical therapy to manage this disease. And if we look, for instance, at vertical bone loss, all these teeth have vertical bone loss, and I've included the surgical pictures here with it that are, these are challenging to manage with just non-surgical periodontal therapy. And this complexity is such that if you don't manage it, it increases the risk for future disease, and therefore the prognosis of these teeth is not great, depending on what prognostic system you use. But these teeth require therapy to increase that prognosis, and that often is surgical therapy. So the complexity is such to where tooth loss is in play, and the intervention tends to be more surgical therapy oriented. If we look at stage four is the stage in which many of the disease parameters are the same. You may still have pockets that are 5 or greater, but the difference between stage 3 and 4 is that you've already lost a lot of teeth. And what you now have is that the lack of teeth makes it difficult to protect the other teeth. So in the stage 3 phase, we still have enough teeth there to still have good occlusion, decent function, and we're not compromising the other teeth because the remaining teeth are taking over the function of all the teeth. So this stage is characterized by the loss of teeth, often greater than 5, bite collapse, no posterior support, trauma from occlusion, and the treatment for these patients tends to be multidisciplinary. It includes periodontal therapy, but it must include replacement of the missing teeth with a partial denture, fixed partial dentures, or potentially dental implants. But without that restoration of the missing teeth, it is hard to treat the periodontitis on these complex patients. There's also an extent and distribution component in this periodontitis staging component, and that is describing whether the disease is localized or generalized. This characterization we can only do if we have full mouth charting. And localized now is defined as less than 30% of the teeth that are involved. Generalized is more than 30%. And in addition to localized and generalized, you can also describe a specific pattern you may observe. A common pattern we see in sometimes see in teenagers is a incisor molar pattern, and that can be described in here. So what is important to understand is that the first thing you do is you diagnose the patient with periodontitis. Then you look at the staging, and then following that, you describe whether or not it's localized or generalized. In addition to the staging, we also can grade our patients. The grading is looking at the rate of progression. So, not just looking at where the patient is and how complex the disease is, but how long did it take to get there? And that rate of progression is very important for us to understand and put in the context of what we think the risk for future disease is. So in the grading, we are looking at how much bone have you lost over a period of time. That is very easy to do if you have a set of x-rays at baseline and a set of x-rays at follow-up. And in this now, we kind of define a rapid rate of the progression to be greater or equal to 2 millimeters over a 5-year period. And a slow rate is really no progression or very limited progression, whereas less than 2 millimeters would be a moderate rate of progression. Again, these numbers were somewhat arbitrarily picked, but they help us with a great guide. Now, that is something that is easy to do if you have multiple sets of radiographs and you can make accurate measurements on those. Again, preferably we would have those vertical bite wing radiographs because other radiographs tend to be harder to interpret. If we don't have multiple sets over time, we can work with one set of radiographs and divide the percent of bone loss by the age of the patient. That's a little bit of a surrogate, but it works quite well. We call that the indirect evidence of progression. And this is now capturing whether or not it's rapid and by a ratio. And the definition of rapid progression now is that your percent of bone loss is greater than the age of the patient, or that ratio becomes greater than 1. I don't need to know if it's 1.6, 1.8. I just need to know it's greater than 1. And that is a simple calculation by estimating the percent of bone loss. If that number is greater than the age, you end up having rapid progression. The harder part to distinguish with this calculation is whether or not you had a grade A or slow or no progression or a grade B. The grade B is anything over a quarter of the bone loss is a quarter of the age of the patient up to about the same as the age of the patient. And I'll give you an example of how that actually can be done quite easily. In addition to looking at just the amount of bone loss that has occurred, we also look at whether or not we have a lot of plaque and no disease, because patients that have a lot of plaque without bone destruction, we're far less worried about than a patient that has hardly any plaque and has bone loss. One of my most challenging patients to deal with in my practice is a 39-year-old orthodontist that has immaculate plaque control, that does a fantastic job at keeping plaque off, but still has bone loss. So in his case, he has a low tolerance to biofilm and exhibits quite a bit of destruction if a little bit of biofilm is left. And that is somebody that fits in the grade C category. And everything in the middle is now middle of the road periodontitis grade B. We do have two grade modifiers that are defined within the classification, and they're known risk factors for periodontitis: smoking and diabetes. In smoking, if you smoke more than 10 cigarettes, then you're considered at greater risk, and we also put you in that grade C category, and that is versus a non-smoker. These boxes
What
are
is
also
10 cigarettes, Nico? In a
greater than 10
lifetime or in a
per
week?
day, per
Per
day,
day. Oh, okay. More than 10 cigarettes per day.
per day, not in a
Okay.
lifetime. No. Um, in the future, I think we're going to add vaping in here. And at that point, I think the rate of vaping is not that important. I think we have some early evidence that says vaping immediately puts you at grade C. We see the time from initiating vaping to permanent destruction of your periodontium to likely be shorter than with cigarettes. But that's a totally different lecture that I may hope to be able to give you at some point as well. So diabetes, well-controlled diabetes, no difference in risk for periodontitis, whereas somebody with uncontrolled diabetes in this grade modifier defined as an HbA1c, one of the measurements of diabetic control, to be equal or greater than 7%. So those are our two risk modifiers. Now, I told you that there's an easy way to work on that grading off of one radiograph. And I'm going to give you a couple of examples to outline that, and at the same time, pull in the significance of the grading. So here's a patient that I made
So,
30 years
Nico,
old.
just I will stop you there because I think this is important. So, I would like everyone to pay attention to this part. We know the image is not very good, but please pay attention on how we can make grading simpler using radiographs.
So if you look at this radiograph here, we have a 30-year-old patient that has 40% bone loss. I immediately can tell that this patient has bone loss that is greater than their age. And that makes them uh, immediately a grade C. I don't have to calculate out anything more. I know that if that patient's 30 years old and the bone loss would be 31%, which my eyes are not that good in distinguishing in one percentiles only. So I tend to look at 30, 35, 40% bone loss versus 31 or 32%. I rarely measure up the full root length. I mean, you could do it in an exercise like this, but that, hold on, like this for each tooth, but that really isn't necessary because we're grading based on the worst site in this patient's mouth. So in this patient, that would be this lateral incisor that in a 55-year-old patient has more than 50%, 55% bone loss, and therefore that would be a grade C. So we were at this patient here, but I'm going to change that up a little bit because now I'm going to make that same patient 70 years old with 40% bone loss. The significance compared to the other patient is that this patient had a long time to get to this level of bone loss, and therefore we are less worried about the progression of bone loss. And that is reflected in our grading because this is no longer a percent bone loss that is greater than the age of the patient. This is also not a quarter of 70. What it is exactly, I don't know, but this is a grade B patient. Grade B patients are at risk for progression, but it tends to not be rapid progression. So, what we're really doing in these patients here is ruling out whether or not this is grade A. And grade A, to me, is a unique grade reserved for patients with tiny little bone loss that tend to be older. Because look at this example here. This is a 50-year-old, and I made up these examples, but this 50-year-old has 10% bone loss. That 10% bone loss is less than a quarter of that patient, and they are a grade A. Is less than 4 times the bone loss. But
Okay, so this patient, he has or she has periodontal disease, periodontitis, but
correct,
the grade of it is not a rapid development of bone loss. So, and also it's less than the age, the percentage of the maximum bone lost in a tooth, in the tooth that lost the most, right? I'm trying to paraphrase
correct.
you to see if I'm understanding.
Yeah. So,
So,
if I
because
were to look at
this
these
person,
radiographs, I can almost immediately say that this patient, just on these radiographs, has and don't do this, but this patient has bone loss, is 50 years old, has local factors. We see calculus on the tooth surface, and only has a little bit of bone loss. So this is likely a stage 1 grade A periodontitis patient. This is a
okay.
patient that has had long-term exposure to the elements and may have lost a little bit, but their susceptibility to disease is relatively low. Now, if we flip this around and we say, well, what if you have 10% bone loss? How old do you need to be to still be grade A? Well, you need to be younger than 40 to be grade A. Okay, that can occur. What if you have 20% bone loss? You need to be older than 40 to still be a grade A. I think I said it wrong earlier. You need to be older than 40 to still be grade A with 10%. The real story is if you have 30% bone loss, you need to be older than 120. So with 30% bone loss, you're never a grade A because we don't have people 120 years old. Um, so the other thing that's important to understand is that you only diagnose one stage per patient and one grade per patient. This is a patient-wide diagnosis, and it is a patient-wide grading. And the reason it's patient-wide is that we diagnose an inflammatory disease that has the potential to affect all the teeth in the mouth. When complexities increase, the risk for those teeth that have those complexities is greater than the ones that don't have it. But overall, that patient is at risk for bone loss at all teeth exposed to bacteria. And the same is true for the grading. So we base both of those on the most advanced sites in the patient. So the stage represents the most advanced area of the mouth. And you can describe it as localized or generalized, but you're not going to describe stage 1 in the upper right and stage 3 in the lower left. That's not possible. That patient would potentially be a localized stage 3 patient based on the most advanced area. So I have just one little example, and this is contrasting out two patients to each other. It's a mother-daughter combination. So the mother is 43 years old, and she has had some issues with bleeding gums since she was 30, and she's already lost multiple teeth because they became loose. So this is the clinical scenario that's associated with that patient. And just looking at these radiographs, I can immediately diagnose this patient as a stage 4 periodontitis patient. This is a stage 4 periodontitis patient, grade C. I don't even have to do any calculations. I can just look at that. Missing teeth, multiple missing teeth, and likely going to miss all their teeth. Now, contrast that out to her 17-year-old daughter. She's had a mother that had bleeding gums. You see her on the left side of the slide, and her radiographs look like this. If we look closely at number 30, there's some incipient bone loss present. And at age 17, this is more than 17%. In addition, she has gingival inflammation. And what to me is interesting to look at is that the path that both these patients are wandering are on the same scale of grade C. But if we look at grade C for the mother, she has lost teeth and she's down in the abyss of potentially full dentition loss, whereas the daughter is still at a plateau where no teeth have been lost, yet the risk for that exists. So we need to intervene with this patient, and we need to make sure that that patient understands that their inflammation has the potential to lead to rapid destruction of bone and therefore needs to be treated. So, how do we treat our patients? That's a totally different language. But what do we do when we have treated them, and how do we interpret this health when it has been established following treatment? This is the category that we haven't talked about. So, somebody undergoes periodontal therapy and ends up with no pockets. If you end up with no pockets and no bleeding, you are still a periodontitis patient. You still have periodontitis, but you're stable. You are a patient with periodontal health. Not having pockets doesn't mean you're no longer periodontitis. This is important to establish because that determines the maintenance interval. And of course, that's individually assessed. For most patients with periodontitis, we'd like to control their complexities and their plaque, etc., more often, and we see these patients about every 3 months. Now, what if that patient that has periodontitis and has health ends up getting inflammation? That's a periodontitis patient with inflammation. And the significance here now is that if you get inflammation when you're a periodontitis patient, that instantly puts you at risk for bone loss, unlike a patient with gingivitis that has gingival inflammation. So we can't call this patient a gingivitis patient because they have no pockets. No, we can only call them a gingivitis patient if they've never lost bone. Now, if bone loss occurs, we now have a periodontitis patient that's unstable with recurrent disease and they require therapy. Okay, I think I went over a little bit, but Joanna interrupted me twice. Thank you, Joanna. But I do want to make sure we answer any of your questions that you may have. And I know this forum may be a good one to ask those questions in, but if not, I'm very happy to answer those in either through emails or through other communications. So are there any questions?
Nico, would you like to stop sharing and turn on your camera?
I can try to do that.
So thank you for your presentation. I think it's very interesting to learn about the Perio classification because it's not something that I learned when I was in school. So we need to play catch up on that. We have one question here. What's the benefit of an aggressive recall interval in a person with stable periodontitis and no inflammation?
Okay, so if a patient has a stable periodontitis, we have to kind of think about why is this stable? Is this stable because there is absolutely no plaque on their teeth, or is it stable because we are controlling that biofilm with a certain amount of regularity? For me, the most important part to understand here is that the diagnosis of that patient remains periodontitis. That patient will have inflammation that can lead to bone loss if we allow plaque to accumulate. So that's why, for me, it is very important to see these patients frequently. One, to mitigate that risk, and two, if disease were to occur, we didn't give it a long time to progress. So we get it at the early stages if we see them every 3 months. Now, as a periodontist, we sometimes think that the dogma is if you have periodontitis, we always see you every 3 months. Um, Not always true, because what we're really trying to do is, are we controlling the disease? Is there no inflammation? So if a patient comes in to you and they never have plaque on their teeth, they don't really have inflammation, then they are treating their periodontitis. By the way, that is what I tell my patients. If they come to me for periodontal therapy, I do my exams, I talk about the grading and staging. I immediately tell the patient that as a periodontist, I do not treat periodontitis. And then the patient looks at me, well, why do I come to you? If you listen to the story, the treatment for periodontitis is not having inflammation, and not having inflammation means there's no biofilm on your teeth. And that biofilm control has to occur in the patient's bathroom or wherever they brush, performed by themselves. Now, I can treat it, but they have to come in every other day and we have to clean their teeth every other day. And no patient has taken me up on that. So I do think this is important to get across, because the patient has to understand that they have to control their disease. Now, what we do as oral healthcare providers is we mitigate the complexities of the disease that make it possible for them to brush. Dealing with very deep pockets is challenging from an oral hygiene perspective every day. So that's a difficult scenario to maintain. So we work on reducing those pockets, creating an opportunity to access furcations, or potentially regenerating lost bone if the disease is very complex, or eliminating pockets surgically. Those are all there to set up an environment in which the patient can treat their own disease.
Okay, it sounds feasible to me. I'm not sure about my patients on doing her home hygiene, oral hygiene every day. Do you have one more questions for Dr. Gers? I would just say that I'm very comfortable with silence. No more questions? Okay, so I put a link on the sites here for a brief survey that we are asking about your confidence on diagnosing periodontitis. So I'm curious to see what you thought about this presentation and if it increased your confidence on that. Dr. Gers, thank you so much for your presentation. We do apologize for the quality of the connection. I think we can do better next time. But I would also like to talk about the bridge projects, and that's why um, we are here, is so that you also learn a little bit more about what is bridges and what we are up to. Okay, so now that we talked about the perio classification and periodontitis diagnosis, I want to present to you a little bit about the Seniors Oral Health in Southeast Alaska, which we are calling the Bridge Projects. First, I would like to reintroduce myself, Joanna Cunha Cruz, Director of Practice and Community-Based Research at UAB, and acknowledge the participation of Search as with Dr. Marcia Wayland as our principal investigator at Search. Previously, we had Dr. Mandy Smith, and she worked with me through obtaining the funding for this research. And now she passed it on to Dr. Wayland. But what is the Bridge program? So one way of looking at it is, and from the NIH and research perspective, it is a prospective study of search patients that are 60 years or older, about 600 patients with periodontitis and or dental caries will be followed over time. The study is funded by NIH and IDCR for 5 years. But what the Bridge program also is, it's not only research, but it's also an opportunity for you to learn and reflect about geriatric oral health and dental care, and also to an opportunity to engage in research and receive continuing education credits. The study team at UAB, we have me, we have Dr. Gers as a periodontist. We have Dr. Nathan Smith. He is a geriatric dentist and general dentist. And we have Dr. Funkhauser, who is our data biostatistician. And our study manager is Lata Rayala. On the search side, we have, as I mentioned, Dr. Mandy Smith was our subcontract principal investigator, and now it's Dr. Marcia Wayland. She is located in Sitka. Besides her, we also have in the team Dr. Lenaker and Clay Crosset as practice administrations that can support the implementation of this study. Working closely with them is Lynn Stephens-Ivers. And working closely with Dr. Wayland, we have Lindsay Birds, a dental hygienist, and Dasha Pisa, an administrator at the clinic. This study will allow Search to hire a research coordinator to support the activities from the study. And besides that, we have collaborators, and that's why it's important that we engage with you because we need your help. As dentists, hygienists, and dental therapists, you are providing care to the seniors. And we ask you to talk about the study with your patients so that they can get excited to participate. And as a dental staff, we would ask for your help to enroll patients and do the consent with them. And finally, in our group, we have a community study advisory committee. Um, we Some of you suggested names of seniors in the communities that you serve. Thank you very much. And they are now members of our committee. We would like to have more people involved from the community, patients from Search, from other locations like Juneau, Hona, Cake, so that we can have a broader representation. But why are we doing this? Well, when we talk about geriatric oral health, we know that there has been an increase in longevity. We are living longer, but that also led to a reduction in tooth loss, which then will that increase periodontal disease and caries in those people that are living longer since they have more tooth now? Well, it may, but the one thing is true, more seniors have oral health care needs, and we need to meet those needs. We need to understand what's going on. The thing is, there are no longitudinal studies in the United States on the outcomes of dental care for older adults. You won't believe me, but it's true. I could not find a study that followed patients over time that have disease to see what happens with them. So this study is trying to do that. Not only that, you are in an amazing work in region where you have many Alaska Native seniors. And we would like to understand how is their health in comparison to the rest of the US population. Because the few studies that we have that are cross-sectional show that Alaska Native seniors are 3 times more likely to have untreated dental caries than the overall study US population, but also 1.7 times more likely to have periodontitis. Is this what's happening in Southeast Alaska? From your clinical experience, you might have that answer, but from a research perspective, we don't have that answer. So this study will try to decrease this gap between research and practice, to try to understand and answer a few questions. What happens with seniors over time when they have periodontitis or dental caries? What are the treatments that they receive? What are the outcomes of this care? Once they receive treatment, do they become stable periodontitis patients, or do they have rapid progression? Are there any measures or characteristics that we can predict which people will have a better outcome? And are the outcomes of care different for Alaska Native seniors? Is it better or worse than other race ethnicities? So this is the basic questions that we will be trying to answer with this study. And the main outcomes, going back to why we were looking at periodontitis today, we would like to know, based on radiographic evidence, if there was successful control of periodontitis progression. Based on treatments of dental caries, we want to also see if there was successful management of dental caries. The primary outcome will be proportion of patients with periodontitis at baseline that exhibits no periodontitis progression over the time that we follow those patients over time. And we will be classifying them in rapid, moderate, and no progression based on the radiographic bone level. For caries, we are interested in seeing if once the patient is identified and received the baseline treatment, which is like the first 6 months of treatment, right? Caries doesn't develop that fast. So if they receive more treatment after the initial 6 months, it means that, well, there might have been new caries treatment, new caries. So let's look at which treatments they received. And if they received new restorations, endodontics, pros, or extractions, we will consider that as a failed treatment. Who will be in the study? Well, we want to have about 600 patients. And for that, we need your help because those patients will be coming from your clinics. And then to participate in this study, the person needs to be 60 years or older, must have had a diagnosis or treatment for dental caries or periodontitis in the last 6 months. So this is people with disease that we want to follow over time to see what happens. They need to be in good general health, that they are able to answer the questionnaire, and they need to be willing to sign the consents and comply with the study procedures, which means they're not planning on moving outside of Southeast Alaska in the next 3 years. Patients that have no natural teeth will not be included, and those that do not speak English, because we won't be able to do the survey. What the patients will do. So that's the part of the patients, what they will be doing. They need to consent to be in the study. So they will sign a consent on an iPad. They will answer a brief questionnaire that's 15 minutes max in an iPad at an initial visit and yearly for the next 3 years. And then they will receive a thank you gift that includes an electric toothbrush. And this was discussed with our search team that is doing the study and also with community advisory boards. And they both thought that an electric toothbrush would be a good thank you gift to the participants. And we might be adding other perks to that goodie bag. What the research coordinator will do, like I mentioned, there will be a research coordinator that will be the primary person responsible for reaching out to patients. So that research coordinator will check if the patient meets the inclusion criteria. They can invite and enroll the patient in person or by telephone. They do the informed consent with the patients in REDCap, which is an online system on an iPad. Then they wait for the patient to answer the survey, and then they give the patient a thank you gift. After the patient leaves, the research coordinator will upload recent radiographs, and that's why it's important to have the vertical bite wings or a bite wing or a regular bite wing or periapicals, so that we can look at our outcome, which is the radiographic bone loss. And then the research coordinator will also look at the charts, medical chart, to look for current medications and diseases. We have contracted with practice analytics that will extract the data from the dentrix. So basically, this is the flow of the study. But then you ask, what can you do? Well, as a provider, you can talk to your patients about this study. Your staff can invite and enroll patients in person or by telephone and do the informed consent. There needs to be some training for that, and we have a plan on training you for doing the consents and using the iPads. You will give the patient a thank you gift, and the staff can also upload the red cap, the recent radiographs. The research coordinator can do the chart review. So again, the preferred radiographs are vertical bite wings. It's also allowed other types of radiographs to be uploaded. I want to be mindful of the time, and I know that Dr. Gers will need to leave now because he has a meeting in 15 minutes that he needs to walk there. So thank you, Dr. Gers, for being here and in our first webinar, and there will be more to come. In terms of data being collected in the questionnaire, we have a few questions to the patients that they will be able to answer them, and we will be able to relate this to predict success of treatments. Those are health history. We are collecting the HbA1c level if it's available in search medical charts. Like Dr. Gers mentioned, that is important to have that measure. Besides that, the data that will be extracted from Dentrix includes all the treatments that you are providing, but we can also obtain information from the notes that are generated from the templates that you complete during comprehensive exams. We will obtain data on the periodontal chart and the hard tissue chart and the details about the visits. Again, the radiographic images will need to be uploaded because they are not stored in Dentrix. It's a different system and we don't have access to that. So the idea that we have is to take a screenshot of the radiographic image and upload to RedCap. This is an overview, like big overview of the study that basically a lot of people will need to be screened to see if they are eligible. If they are eligible, we will obtain informed consent and do the questionnaire. And then every year, we will do follow-up assessments where they will be asked to answer the questionnaire again for 3 times. Participants will be enrolled from August 2024 until May 2025. So we have 10 months to enroll 600 patients, which means about 60 patients a month. And then they will have the yearly examinations. So this is the timeline. This is our projected timeline. We have been, for the last year, obtaining approvals from IRB and NIDCR, and it's a long process, and search too, to be able to access the data. So we are still in that process, and my hope is that we can do protocol training and human subjects research in July, and then start patient enrollment in August, and then roll out, start in Sitka and roll out to other clinics over time. So as you can see, the bridge programs involve seniors, data managers, and providers. And it's a group efforts for us to understand how is the care that's being provided to seniors in search. It's a way to reflect about that care and over time improve the care that's provided. I would like to thank you for the opportunity to be doing research with your organization. It's been since 2014 that I've been involved in some way with search, and I'm always impressed about the commitment and the dedication and the care that it's provide to the people in Southeast Alaska.